Good morning, conference. Good morning, Liverpool. It's wonderful to be here. This is the 11th RCGP conference. It is the finest general practice conference in the world. You can expect a smorgasbord of courses, presentations, sparkling networking, and some inspiring speakers. I'm Helen Stokes-Lampard, and I have had the great privilege to be your chair for almost a year, and it has been a most remarkable time. But I'm not just your chair. I'm a GP. A real GP. I'm a partner in a surgery in Lichfield, just down the road in Staffordshire. And I know all too well the challenges we're facing. It's tough, and it's probably never been tougher. But we are at a time of great opportunity. As long as general practice receives the support, the resource, the staffing we need, I do believe there can be joy in the consultation. Now, I had planned a normal sort of chair of the college type speech, but I've decided today I want to tell you a story. I want to talk to you about Enid. Now, all of you who are GPs and work in surgery sort of know Enid. I think you recognise her. You'll recognise her in your own lives, in your own communities. Enid's 84. She has hypertension. It's well controlled. She has type 2 diabetes, which is controlled with diet. And she has osteoarthritis, so she has pain in both her hips from time to time. Enid has kind eyes. She has a warm smile, and she always dresses up when she comes to see me in the consulting room. But last year, Enid lost Brian, her husband of 62 years. They always used to attend appointments together, sometimes chiming in on one another's appointments, holding hands anxiously if they anticipated bad news. And we have had our share of bad news as Brian's prostate cancer took over. Brian was her rock, her best friend, but also the butt of all those little jokes she made. But now Brian's gone and Enid's living on her own. And society is just a bit uncomfortable about Enid, an ageing widow who's a bit frail. I want to be clear, Enid's a lovely lady. She has her own home, it's small and manageable. She's coping on her widow's pension. And she's got family, a daughter and some grandchildren. But they live 180 miles away and they all work full time. Enid's fiercely independent. She's a little bit forgetful, but she doesn't fit the diagnostic criteria for dementia and she wouldn't want to be screened anyway. But Enid got a bit snappy with some of the reception staff recently. She's been a bit more demanding on time in the practice, coming more than she used to. And I overheard talk from the receptionist about we need a strategy to manage her. Now, the guidelines say, indeed the computer alerts flash at me, that I should be taking Enid to task, talking to her about her weight, encouraging her to exercise more, and I should be prescribing a lot more medication. But you can all see that Enid's main problems aren't medical. She's lonely. After a life spent living with another person, she is now alone. When she wakes up, her house is silent, and when she goes to bed, there's no one to say goodnight to. So, like you, I didn't follow the rules. I chatted. I listened. I did what all good GPs try and do. I saw the world through Enid's eyes in our precious few minutes together. I prioritised what Enid wanted over QOF, over guidelines, what the CCG says, because they're only guidelines. Sometimes I offered her a bit of advice about a new class, a group, a charity, something in the community that I thought might suit her, might help her health and well-being. I gave her permission to miss Brian. I gave her permission to move on with her life. I gave her permission to carve out a new normal. And in the final moments of our consultations together, of course, I do turn to the screen. I update things as accurately as I can. I tick a few boxes. And I do everything that the computer, in its well-intentioned but binary way, tells me I should be doing. Because someone will be watching, processing the data to see if I'm a good doctor. Am I using the consultation wisely to attempt to minimize variation between myself and a prescribed best practice? Nowadays, someone's always looking over our shoulders. Now, in the end, Enid connected with a local primary school, a really great scheme which links mature women with young mums who are isolated and lonely, because social isolation and loneliness are not just the preserve of the elderly. And this project, which recognises the life experience of these older women, women who've lived their lives and brought up children and have so much to share, was exactly what Enid needed. A couple of hours, twice a week, where she is needed, she's valued and appreciated, and she uses her life of experience to help someone else. So, Enid isn't making GP appointments as regularly as before. She's not taking up space in a hospital bed for a hip replacement that she didn't really need. She's not taking antidepressants. Actually, she's not taking much medication at all. But she did come to see me a few weeks ago, something routine, and I noticed Enid started wearing makeup again. She's had her hair done for the first time since Brian died. So you get the picture. Social isolation and loneliness are akin to a chronic, long-term condition when it comes to the impact they can have on our patients' health and well-being. They're not medical conditions. They're not something that we can treat with pharmaceuticals or a referral for treatment in secondary care, but they must be addressed if we are to be truly patient-centred. When the NHS was established, society was different. 70 years ago, life was different here in the UK. Generations of families lived closer together. People had better social supports and communities. People felt part of something. Now, I'm not the first person to be speaking about this. Over 30 years ago, a study in the college's own rather wonderful British Journal of General Practice considered the impact of loneliness on older people's health and well-being. It looked at people a bit like Enid. They were over 70, some widowed, and it found that the lonely did consult their GP more often. In many cases, their GP was the person with whom they had the most contact. Now, back then, the focus was mostly on physical limitations, loss of hearing, reduced mobility. But nowadays, as we strive for parity of esteem with mental health problems, it is vital that we consider the mental health impact of loneliness and social isolation too. Another BJGP study, this time 1999, it found that lonely and socially isolated people visit their GP far more often, in some cases not because they were more unwell, but because they wanted someone to talk to. In fact, the GP was the person they had the most contact with. They just wanted human contact. In 2010, research in PLOS medicine looked at 158 studies covering over 300,000 people, and their findings indicated that lonely people had a 50% higher risk of early death compared to those with good social connections. And just 2 years ago, a huge meta-analysis in the US of over 70 studies covering 3.5 million people, published in Perspectives on Psychological Science, if you're interested, on how social isolation, loneliness and living alone affect premature mortality. I found for those who are lonely, the likelihood of an early death increases by 26%. For those who are socially isolated, increases by 29%. And those living alone, the likelihood of early death goes up by 32%. I concluded that those risk factors are akin to the well-established risk factors of physical activity, obesity, or having a mental health disorder on longevity. Of course, this doesn't just impact on primary care. This hits secondary care too. There are patients in hospitals up and down the country who just don't want to go home. Despite the indignities and lack of freedom, they have a community in hospital. They are not lonely. Loneliness inevitably takes its toll on the entire health and social care system. Now, there will be robust debate as to whether addressing loneliness and social isolation is the role of the GP, indeed the NHS at all, at a time when we have so much to do and the demands are ever increasing. And some would say that GPs, by even considering the impact of loneliness, then we're medicalising a completely normal part of human existence. That's not what I'm saying. My view is that if something is adversely impacting on our patients' health and well-being, we have a duty to recognise it and seek solutions. Enid didn't need drugs to cheer her up or mask her pain. She needed a cure for her loneliness. She needed human contact. And I was happy that I could signpost her to a system, a scheme that would work just for her. So Enid's story is ongoing. Right now, it's going well. But it is not always possible right now to deliver this level of patient-centred care. We need the time, we need the staffing, and we need the resources to do it. In another practice, one that's larger than my own, I might have been able to get Enid some time with a care navigator or somebody who can socially prescribe, someone who could spend the time with her and find opportunities for an Enid-shaped space in society. I'd really like that. I'm looking forward to that. And actually, there are a remarkable number of initiatives out there to help people who are lonely and socially isolated, like Enid. The aim to minimise the impact of these things associated with advancing age, the initiatives are great, and I'm going to share a couple with you. If you've got the time, and I'd recommend that you find that few moments to do so, look at the college's website. CIRC, our Clinical Innovation and Research Centre, has a Bright Ideas portal. It's fab. If you want a sparkle in your life, look at the Bright Ideas website. You might come across Prime 75. Now, this is an initiative that was submitted by a practice manager, Di Waller. It's the Arden Medical Practice in Stratford-on-Avon. They identified their ageing population as a cause for concern. And they commissioned a service to identify patients over the age of 75 who might be frail, lonely, socially isolated. And they set up special services for them to empower them to take more control of their own well-being. Another initiative by Claire Key of the Shoppick Surgery in Hertfordshire, they launched the housebound service so that looking after their elderly housebound patients wasn't just a tick box exercise to ensure they received holistic care. It's simple and it's brilliant. And I'm not sure how many of you caught a wonderful documentary on Channel 4 this summer, but it followed a group of people, a group of children, nursery school children, whose nursery school was moved into an elderly people's residential home for 6 weeks. It was an experiment which aimed to explore the impact of this intergenerational mix on the health and well-being of the older people. Many of these people reported feeling lonely, had no immediate family or friends. Now, there was scepticism, not least from some of the residents, one who said it was going to be a total disaster. But actually, there was a marked improvement in the health and well-being of the residents, both physical and mental health. They walked faster, they were happier, and they got more involved in life. And this is what I mean when I talk about joy in our professional lives, joy in the consultation. And it showcases the fantastic potential of general practice and healthcare in general to innovate when we have time and resource for some headspace to do so. I firmly believe that human beings are spiritual creatures. What makes us unique and special is so much more than our genetics and our environment. It's the things that make our hearts beat faster. It's the things that make us buzz with anticipation. It's the things we love and the things we hate, the things we dread and what we get excited about. Now, that may be the love or the touch of another person. It could be soaring music, great wine, or a magnificent view. But to deny our spirituality diminishes us. Earlier this year, I was privileged to visit the Bromley by Bow Centre in London with the centre's founder, GP, fellow of this college, Sir Sam Everington. Now, as well as a thriving GP surgery out there in East London, it's home to several social enterprises, a park, beautiful gardens, a church, and numerous other facilities. And there are several artists based there working alongside a social prescribing team who use motivational interviewing techniques to help members of the community. And they found that this reduces dependence on GPs for issues that are more social than psychological. As GPs, we cannot fix all of society's problems, but we do get to see and feel them. And we need to recognise their impact on patients' health and have strategies to help our patients whilst at the same time protecting our time to be doctors. If we attempt to fix everything, we will burn out. Let's be quite clear about that. And right now we are burning out. The GP Health Services launched this year throughout England as part of the GP Forward View and run by our fabulous former chair, Claire Gerarda. It already has over 800 GPs subscribed to it. 800 GPs that desperate they need help. Trust me, we know how big this problem is. And this is why We need the £2.4 billion a year extra for general practice promised in the GP Forward View, championed by our other fabulous former chair, Maureen Baker, delivered in England in full. And we need equivalent promises in Wales, Scotland and Northern Ireland, and we need them fast. We need to boost our workforce. We need the appropriate numbers of GPs and the entire healthcare team to ensure we can do our jobs safely for the benefit of our patients and our own well-being. Now, the NHS is there to provide healthcare free for all at the point of need. As GPs, expert medical generalists and consultants in general practice, we are there to ensure care takes place at the front line and to act as gatekeepers for the rest of the NHS. We are the bedrock of the NHS. So, I'm going to take you back to Enid. It's warm up here. I am not Enid's friend. I'm not her daughter. I'm not her counsellor. I am her GP. During our moments together, Enid is the focus of my professional world. She knows I will do everything I can to get the best outcomes for her. Now, that may not be longer life. It may not be the medication or the treatment that the computer's telling me to give her. But it will be Enid-shaped care. That is what we should aspire to. This should be the future of general practice, Enid-shaped care. In February, our RCGP Council, made up of members elected from throughout the UK, frontline GPs. We passed an updated position statement on quality. If you've got the time, do read the full report on our website. It is a worthwhile read. But in summary, it says that we should act with kindness, empathy, honesty and integrity, that we should listen and share decisions in line with patient preference. It talks about quality as providing person-centred and coordinated care, understanding the interaction between the physical, social and psychological elements, and working closely with key partners, such as the extended primary care team and the voluntary, community and social care sectors. Mahatma Gandhi said that a nation's greatness is measured by how it treats its weakest members. That's our vulnerable, our elderly, our frail, our isolated. In the UK, we live in an affluent, civilised society, and however hard things get, however tough it feels, we must remember that. Cum scientia caritas, the college's motto, scientific knowledge applied with compassion. It really has stood the test of time. So, I call right here, right now, on the four governments of the UK for the time, the resources and the freedom that we need to do what is right for our patients, to innovate in their best interests, to act in their best interests, to allow us to deliver Enid-shaped care to Enid. And I want to deliver personalised care to every single one of my patients. I want to restore the joy to general practice. Deliver the GP Forward View in England in full, as the college has repeatedly said. We know there's progress, but GPs at the front line are not feeling it, so we need things fast. In Wales, Scotland, Northern Ireland, give us equivalent promises and deliver them. But resources and workforce are not everything. Give us the freedom to deliver the care our patients need. Give us the time to care. Don't make us spend it ticking boxes, preparing for inspections, or worrying that we haven't followed guidelines for fear of repercussions. Trust us to be doctors. Let us treat our patients like human beings and tailor treatment to their needs. Let us have the resources we need so we can spend longer with those patients who need it. I'm not asking for generosity or excess. Give us enough resource, enough time, enough people, and enough professional support and encouragement. And we will give you great general practice. I want to give great care, Enid-shaped care. That is why I became a doctor. That is why I am a GP. And that is... Thank you. That is why I will do everything in my power while I am your chair to restore the good days to general practice, to make our profession a place where practicing GPs are supported and given the respect that we deserve, the medical profession of choice, where GPs can enjoy working through their entire careers, a profession we can all be proud of. Thank you all so much.